Today we will talk about head injuries. This talk is prepared by myself. I am Dr. Uday Ghate, Associate Professor in the Department of Surgery, and this talk has been approved by Dr. Sheetal Murchute, Professor and Head Surgery. Regarding the definition of head injury is defined as any trauma to the head other than superficial injuries to the face. This is according to the British Guidelines 2017. Traumatic brain injury is a non-specific term describing blunt penetration or blast injuries to the brain. Traumatic brain injuries can be classified as mild, moderate or severe. This classification is typically based on the Glasgow Coma scale, which we'll talk about in detail later. Considering epidemiology, around 1.4 million attendants in emergency department in England and Wales are seen with head injuries. Out of that, 200,000 admitted to the hospital per annum. Road traffic injuries are the leading cause of the head injuries, constituting almost 60%. They are followed by falls around 25% and violence in 10%. The incidence of head injury per 100,000 population per year ranges between 150 to 450. The incidence of head injuries is increasing with increasing number of vehicles. Among the road traffic accidents, 70% have head injuries. Out of these 70% of patients, roughly 5 to 10% have fatal injuries where they have risk to their life and they can die. Most frequent age group is seen is 20 to 40 years of population. Basically, this is common in youngsters. Head injuries commonest cause is the road accidents. As we said, next is fall and assault. This is less common in females, and prevention of head injuries should be the aim if we consider high number of casualties from the road traffic accidents. Coming back to the etiology of the head injuries can occur because of the road traffic accidents, falls, from the sports injuries, assaults and war injuries where you normally see penetrating and blast injuries. When we talk about the biomechanics of the head injury, how the head injuries can occur, this can occur by two ways. First is when the head is moving and the moving head hits against the stationary object. For example, a person riding a motorbike has an accident and he comes out of the bike and hits his head on the cement road, he will get head injury. Or if your head is stationary and the moving object hits the head, for example in assault, if a person is hit by a hammer on his head where the head is stationary but the object is moving, he can also get significant head injury. The spread and force of impact decides the degree of injury. When we consider anatomy of the scalp or the skull, outermost layer is the scalp, then you have a bony skull, then you have different meninges, then underneath that you have brain tissue and there is a CSF and the blood. We have a picture of a scalp here which has got different layers. The outermost layer is the skin. Underneath the skin there is a connective tissue which is dense and you can see numerous blood vessels in the connective tissue. Underneath the connective tissue you have a gallia aponeurosis, then there is a loose connective tissue. Then just above the cranium is the pericranium. Normally it is called as pericranium because it is a part of the outer layer of the bone, and then you have a bony skull underneath that. A patient coming to the hospital with a history of head injury, certain things are important. First thing is to know the history, exactly what happened to the victim, timing of the injury, was it associated with loss of consciousness or vomiting, was there any ear, nose, throat bleed, and was there any episodes of convulsions or whether patient is unconscious. This comes in the initial assessment of the patient. Second thing, we should send routine blood investigations from the casualty itself, which includes complete blood count, electrolytes, clotting, and you should know the patient's blood group as well. And the next investigation is a specific radiology. The specific radiology includes the X-rays and CT scans.
Right.
Again, coming to the history, the mode of injury, time of injury, and the initial Glasgow Coma score, considering other injuries also important. The Glasgow Coma score is derived in a city called as Glasgow in England. There are three components. One is the eye response, second is the verbal response, and third is the motor response. So when the patient opens eyes spontaneously, the score is 4. When the patient opens eye to verbal commands, the score is 3, and so on. When there is no eye opening, even to the painful stimulus, the patient gets score of 1. Same thing is in the verbal response. When the patient is oriented, he can tell you the time, place, etc. He gets 5 marks. And when there is no verbal response to the pain stimulus, then there is a 1 score. The base motor response is considered as the deciding factor in the head injuries. The maximum score you get 6 when the patient obeys commands, like for example, show your tongue, lift your hand, close your eyes and open your eyes, etc. And when there is no motor response to the pain, the patient gets score 1. So score 15 out of 15 is the good score, and score 3 out of 15 is considered as a bad score. Anything below 9 out of 15 is considered as a comatose situation. You also need to check the pupillary reaction. You need to check the both pupils, size of the pupils, and the reaction to the light. When the pupil is dilated, there is evidence of a third nerve palsy, and in this condition, there is a coning of the brain or herniation of the brain. You need to look into the other injuries, associated facial bone fractures, long bone fractures, chest abdomen injuries, and pelvic injuries. As I said, this is a list of the investigations you need to do into the blood. Specific investigations: X-ray skull, CT head, CT facial bones, and cervical spine X-ray, because almost 15 to 20% of these patients will have associated cervical spine injuries. Skull X-rays will show you the linear or depressed fractures. They will also show you if there is air inside the head, and then they will show you the presence of foreign bodies. This is the example of a linear fracture on the CT scan. This is the example of the depressed fracture on the CT scan, where the part of the skull is broken and causing pressure on the underlying brain. This is the example of foreign body. This is penetrating injury into the skull. CT scan will show you different fractures, foreign bodies, and it will also tell you about the presence of extradural or subdural hematoma. And then there are small contusions, which are actually collection of blood into the parenchyma. This is example of a CT scan, which is showing depressed fracture and pressure on the underlying brain. This is example of CT scan which shows significant air inside the head. Again, it is called as pneumocephalus. This is example of extradural hematoma on the CT scan. The extradural hematomas are normally lens-shaped. They are limited by the sutures of the skull. This is example of the subdural hematoma. They are not limited by the sutures of the skull, because they are just on the surface of the brain. These are the contusions where you see small blood clots in the parenchyma. This is the example of cervical spine X-ray. You can see there is a subluxation of the 4th and 5th vertebra. So you need to get the cervical spine X-rays as well when the patient comes with the significant head injuries. Considering management, all patients should be nursed in 30-degree in proper position, because that helps to improve the venous return. You need to start the osmotic diuretics, mannitol 20%. You also need to start anticonvulsants. You need to get the general care of a urinary catheter, skin care, eye care, etc. Also, you need to keep eye on the patient nutrition as well. When there is a concern about raised ICP, patient is unconscious, one pupil is dilated, and there is a weakness of the arm and limb, and the CT scan shows significant increased pressure inside the head. These patients needs surgical intervention in terms of evacuation of the hematoma, either extradural, subdural.
Shot.
This is something about brain herniation. When the ICP is the intracranial pressure, goes beyond compensation state, then there is a transtental herniation. This means descent of a temporal lobe against tentorium. This causes dilatation of pupil because of the compression of the third nerve. Then there can be subfascial herniation. One side of the brain goes to the opposite side of the skull under the falx, and then there is a foramen magnum herniation of a tonsils, which is cerebellar tonsil herniation. Thank you.